Now, I should say before I go any further, I'm not entirely certain. Well, actually, let me strike that. I am certain why the philosophers call this a slippery slope argument, because technically it's not a slippery slope argument at all. A slippery slope argument is technically something that is causal in nature. Whenever you make a slippery slope argument, that's of the following form. It's like A causes B, which causes C, which causes D. We don't like D, and so therefore what you're proposing is bad. Now, in philosophy in general, slippery slope arguments are regarded as fallacious. And so my guess is the reason they call this a slippery slope argument is so they can poison the well a little bit. They want to say that this argument being made here is bad, so they kind of make, well, I don't know if making fun of it's the right word, but they, as I said, poison the well a little bit. They by calling it a slippery slope argument. But what this is actually is this argument that's being made here, this challenge to the philosophers, is really a challenge about the consistency of a particular view. What is the moderate view when it comes to defending a right to die, or when it comes to defending physician-assisted suicide? And I spelled this out a long time ago, but the so-called moderate view about physician-assisted suicide is just this, is that physician-assisted suicide should be limited only to those cases of people who are terminal and who are in a lot of pain. Physician-assisted suicide should not be extended to people who are not terminal. A physician-assisted suicide should also, while it should be illegal, euthanasia should not be legal. But the challenge being presented here is, how can you maintain that line? How can you maintain the line between those who are terminal and those who aren't? How can you maintain the line between physician-assisted suicide and euthanasia? Because it seems like you can't. Once you say that the basis and the justification for assisted suicide is that it is an extension of a person's autonomy, well then why do they need to be terminal? If the basis of physician-assisted suicide is that it's an extension of the person's autonomy, then can't you argue the exact same thing for euthanasia? And so this, in my opinion, it's a very strong argument. Now, depending on your own point of view, it's going to determine whether or not you think this argument is, it's a nail in the coffin to the right to die movement, or if you think it just extends a person's individual liberty. I mean, if you look at Dignitas, they would look at this and say, hey, this just shows that we should allow more liberty and more people should be allowed to kill themselves. I think the vast majority of people, though, they're going to think this is a big problem with the arguments for physician-assisted suicide, because the vast majority of people, they don't want it to be allowed for people who aren't terminal. The vast majority of people don't want people to be able to kill themselves if they're perfectly healthy. I think many people find that to be very disturbing, that anybody would defend, a 25-year-old who is perfectly healthy to defend their right to die. That it seems like the best cases for those being allowed to kill themselves are precisely people who are terminal and people who are in a whole lot of pain. And again, the vast majority of people, you can look at surveys and Gallup polls, 90-some% of people are against euthanasia. You don't find that much consensus about anything. And so, yet again, it seems like once you go down the route of saying physician-assisted suicide is allowed or should be legal due to the fact that it's an extension of a person's individual rights, then why not allow euthanasia? Why can't I say you should be able to kill me? And that's protected by my right to bodily rights. And the philosophers have a response to this, and what they say are two things. They say, well, number one, we can rule out some extremes. Because they're going to say that a right to die is only protected by people who are competent. It should be limited to them. And so competence here is going to mean that you have to be at least 18 years old. I mean, they don't want a 16-year-old whose girlfriend has just broken up with them to kill themselves. Nobody wants that. They don't want it to be allowed for someone who's suffering from paranoid schizophrenia. They don't want physician-assisted suicide for someone who has dementia. They don't want it for any of those. So they'll say, well, number one, it's going to be only for people who are competent. So we can rule out, worries about people who are incompetent. And they say, as far as the rest of it goes, that's what the courts are there to decide. The courts are there to figure out what is and what isn't constitutional. Now, I have to say, I find the first response to be a legitimate one, but the second one just seems like they're being evasive and dodging the real issue here. Because the real issue is not that we can't have the courts make decisions, but rather that if you base the justification for physician-assisted suicide on autonomy, then the only decision that the court's going to be allowed to reach is that it should be allowed for those who aren't terminal. That the only decision that the court's going to be able to reach is that euthanasia should also be protected, because if it's just a function of someone's autonomy. So, in my opinion, they do an okay job when it comes to saying, okay, it has to be limited to people who are competent, but they don't really answer the real worry here, which is just that once you commit yourself to this justification that physician-assisted suicide is allowed on the grounds that it is a function of someone's personal freedom, that it should be protected because it's a function of the person's notion of dignity, then once you say that, then there's just no in-principle line that you or I or the courts or anyone could draw between the cases that we do think, we do have some sympathy for, and those cases which we think, no, you shouldn't be allowed to kill yourself if you're healthy. No, you shouldn't be allowed to have someone else kill you. There's no way we can draw those principled lines. So I find the second, this is just me speaking, you might disagree, and that's okay, you're allowed to disagree. But I find the second part of their answer to be a little unsatisfactory. Then they turn to what they call the practical slippery slope argument. And this actually is a slippery slope argument of the true nature. And what this argument is saying is something different from what the first argument was saying. The first argument was saying this is the first argument, is that your justification commits you to a stronger position than you want. And your justification commits you to a position that nobody wants. The practical slippery slope argument, however, is saying something different. It's saying that if you allow physician-assisted suicide in actual practice, it's going to lead to all kinds of abuse and misuse. In actual practice, if you allow for physician-assisted suicide, it's going to have people who killing themselves who really shouldn't be killing themselves. You're going to have your view is going to have disastrous consequences. So notice the difference between these two, because I always have a little bit of confusion. The so-called theoretical slippery slope argument is not objecting to the kinds of real-world consequences that are going to be produced. It's saying your thinking is inconsistent. This one that we're looking at right now, the practical slippery slope argument, is saying your view, if enacted, is going to have bad real-world consequences. So that's the big difference. And so here what we find is what people argue is they say, look, this is going to lead to all kinds of problems. And two of the main ones are going to be things like misdiagnosis. Because it does happen sometimes that people are misdiagnosed. It does happen sometimes that people are given 6 months left to live, but they end up living, 5-10 years. That does happen. And so what you want to avoid is someone who's been told you've got 4 months left to live and them killing themselves when they could have actually lived another 6 or 7 years. That's something. You're not terminal if you have 6 or 8 years left to live. That's not considered terminal. Terminal is typically considered 6 months or less. We also worry about the voluntariness involved here. And in particular, when we talk about the voluntariness, is a right to die, or you killing yourself, it's only going to be allowed to the extent that it's a genuine expression of what you want, that it's a genuine expression of your free will. But what if you're being forced to kill yourself? Well, then that's not right. That's not something that should be allowed. And you can be coerced or forced in all kinds of different ways. Like one way you might be forced or coerced is in a very kind of subtle way where your family is putting certain kinds of pressure on you to kill yourself. And I know that sounds really messed up and perverse, but it's the reality of things that, family members will start to think in the following ways. They'll think, well, dad is sick. He's, in a lot of pain. He's got this condition. He's not going to get better. He can fight, what he's dealing with for the next 6 months to a year. Medical expenses are really high. So by him fighting this, he's going to blow through all the money he has left. Now, why should dad, sink $200,000, let's say that's his life savings, into fighting something that he's just going to lose, when if he just went ahead and killed himself now, I could get that money and put it to a lot more good in my life. I know that sounds like a really messed up way of thinking, but it's the reality of life, is that people will think that way. People will, subtly pressure, if not explicitly pressure, family members to kill themselves. Not only that, but even if people aren't explicitly saying anything, people who are suffering, a lot of times they don't want to be a burden to those around them. And so they'll feel a pressure to kill themselves just because they don't want to be a burden. There's another concern here about voluntariness that comes up, which is just this, is that people who are suffering, a lot of times it's their pain that's talking, and it's not an actual expression of their own free will. If you're suffering, if someone let's say someone were to put your head in a vice. Let's just say someone were to torture you. They put your head in a vice and started clamping down. You tell them anything that they wanted. You tell them that you started the Great Chicago Fire if they subjected you to enough pain. And so you take someone who's suffering from cancer, let's say, and they're just in agonizing pain. Well, for them, they might request death, but that's not something they really want. That's the pain talking. That's not a genuine expression of what they want. And this is a fact, is that the majority of people who have their pain treated, their request for death goes away. They no longer request death once their pain is managed. And there are genuine worries here, too, that if physician-assisted suicide were to just become widespread and legal, that would take away the incentive for better and better pain management to be developed. Why worry about developing a better and better pain meds if the option is on the table for a person to kill themselves? And one final point here about voluntariness is people who have suffered for years and years with a certain illness. Let's say someone has battled cancer year after year. They've gone into remission. Now the cancer has come back. They've gone through this back and forth. A lot of times the person just becomes depressed as a result of their condition. And here's the thing. Doctors who specialize in cancer treatment are really, really good at fighting cancer, but not always the best at diagnosing depression. To diagnose depression, that actually requires, even medical personnel are bad at diagnosing depression a lot of times. Even medical personnel are bad at it because people can disguise their outward appearances or their inward appearances by putting a good face on the outside. People can pretend to be, one way when in reality they're really suffering. And so if a person is suffering from depression and they request death, you might not be aware that they're actually depressed. And so it's not the person who is genuinely wanting death. It's not an expression of their free will. It's really their depression talking. So these are the kinds of concerns that crop up to say that basically if physician-assisted suicide were allowed to be legal, then we would have all kinds of actual problems in reality. Well, what the philosophers say in response to this is they have a kind of complicated response. And they say, number one, we can put safeguards in place. We can put safeguards in place and we can limit risks. Now, what's interesting about their response is they do not deny that if physician-assisted suicide were legalized across the board, that it would be abused. They are fully aware that it probably will be abused, and that's the reality of things. But what they say is we can limit risks. We can minimize those cases when it would be abused. And what they do is they draw a comparison with patients who refuse life-sustaining treatment. And they say, look, even if you look at patients who refuse life-sustaining treatment, who want a feeding tube removed, or who want to be removed from a respirator, in those cases, we run the risk that that will be abused. We run the risk that certain kind of covert family prejudices might interfere, or maybe maybe someone wants the feeding tube removed from dad, not because it's truly what dad would have wanted, but they just want to get dad's money. We run the risk of abuses even in those cases, but they say, but we have certain protocols to limit those kinds of risks. And if we look at, for instance, a place like the state of Oregon, the state of Oregon establishes a number of protocols to try to prevent any kind of abuse. And so you can see it here, that you must be at least 18, terminal illness with 6 months left. You must have confirmation of your terminal illness by a second physician. You must be able to make medical decisions for yourself. You must be a resident of Oregon. 2 oral requests to a physician at least 15 days apart. So, they want it 15 days apart because, anybody who's having a bad day, they might, just say, kill me over and over. They might just repeat themselves. But if it's 15 days apart, that tends to be a sign that there is some, conscious, deliberate thinking behind it, a written request by patient and 2 witnesses. And then attending physician must report all the lethal medications to the Oregon Health Authority. And that's because they don't want, the reason they want these medications reported is they don't want them just, being out there for anyone to get. They don't want them being abused. And by having a system where we can actually keep track of them, that hopefully is going to reduce any level of abuse. So if you're interested, here's actually the form that you'd have to sign for a request for medication to end my life in a humane and dignified manner. You can look over it here. You can pause the presentation and you can read through it. Here you see your first oral request down here towards the middle of the page. Patient confirmation, physician information. You notice right here, let's see. So the psychiatric evaluation. So for Oregon, you have to undergo a psychiatric evaluation and check one of the following. I have determined that the patient is not suffering from a psychiatric or psychological disorder or depression. And you click, you check it right here. Medical consultation, check that. So, they do have in place a system to try to prevent that kind of abuse, that you do have to undergo a kind of psychiatric evaluation. So with looking at that, the question is, do you think that the safeguards set in place by Oregon seem sufficient to stop abuse? Do you think they'll stop all abuse? Or do you think that any potential abuse, that results is acceptable? I have these questions here for you to think about. And I'll just kind of go ahead and answer them. My opinion is, will they stop all abuse? Clearly not. They're not going to stop all abuse. The question for us is, they're going to be actually a couple of questions, but one big one is, are the protocols that Oregon set in place, are they curtailing, are they limiting the amount of abuse? And the abuse that does appear, is that allowable? Are there good reasons why we might want to make physician-assisted suicide illegal? Well, a good way of figuring out whether or not these predictions would be true, whether or not physician-assisted suicide would lead to horrible consequences, is just look at what the data says. And the state of Oregon has had physician-assisted suicide. It's been legal there for 15 to 20 years, somewhere in that time period, and there's an extensive amount of data that's been collected. Now, I have to confess up front that data is always open to interpretation, but here are some important things to note about whether or not physician-assisted suicide has actually proven to create a lot of problems, whether it's been abused and that abuse has been extensive, or that abuse has been within reasonable measures. And one thing we can say here, and I didn't mention this earlier, and I should have, is that one of the big concerns that people had, and this goes back to the voluntary aspect of physician-assisted suicide, is they thought that by legalizing physician-assisted suicide, it would basically prey on the poor. And the reason that people worried about this is because they said, well, look, Wealthy people can afford all kinds of expensive therapies and treatments. These aren't available to poor people. They don't have adequate health care. And for this reason, poor people are going to be shoehorned into killing themselves because it's a cheaper option than undergoing very expensive therapies and pain management care. As it turns out, that prediction doesn't seem to have been true. It seems that most of the people who have requested and used life-ending treatments have been from mostly middle-class people who had health care and good access to hospice care. There was, like I said, this worry that physician-assisted suicide would prey on the poor. It doesn't seem like that's entirely true, that's been proven to be true. But what about the other kinds of worries that I had mentioned earlier? What about concerns for patient competence? Well, this is something that is a little bit more worrying, and here's why. I said that patients have to be competent in order to get medication to end their life. Now, here's the thing. In our country, you can engage in what is known as doctor shopping. And doctor shopping is basically you can go from doctor to doctor to doctor until you get the diagnosis that you want. There was a well-known case of a woman named Kate Cheney who was deemed incompetent by a number of doctors, and so she just kept going to various doctors until one of them said, yes, you're competent. I should say two of them said, yes, you're competent. And once you have two people say, yes, you're competent, then you can get the life-ending medication that you want. There's a couple of right-to-die organizations. One is called Compassion and Choices, and they have actually what is known as a friendly doctor's list. And this doctor's list, you can look on and say, okay, Dr. Singh, Dr. Smith, Dr. whoever, they will, try to deem me competent if they can. And there's immunity for doctors who act in good faith. Now, if someone comes in and they are clearly schizophrenic, if they're clearly not competent, then the doctor can't have reasonably be said to act in good faith. But if it's at all borderline, or if a doctor can say, well, they seem competent to me, then that doctor has immunity. That doctor can't be prosecuted by law. And so this is, I believe, a big problem in terms of, or at least it's a problem, it's a concern in terms of whether or not the person is competent. Because in order to be able to obtain life-ending treatments, in order to be able to get medicine to kill yourself, in other words, a precondition for that is that you are competent. And who determines if you're competent? Well, a doctor. Well, you can shop and find the doctor you want to determine that you're competent. You can shop and find the doctor to determine that you're terminal, in fact. One doctor might say you're not terminal. Another doctor might say that you are terminal. All you have to do is consult the friendly doctors list, and they'll help you. As long as that doctor acts in good faith, then they're immune from any kind of prosecution. Not only that, but there's actually a time lag between the prescription and when the person actually takes the medication. So here, the concern is that even if you are competent when you're given the prescription, if you take the medication, 6 months from now, or 7 months from now, or what is in most cases a year from now, you might not be competent when you take it, right? Say a person is deteriorating rapidly, they're deemed, hey, yeah, you're competent, you're of sound mind and judgment, but then they have, stroke in between when they're prescribed the medicine and a month from now. Well, they may no longer be competent, and yet they're taking medicine and killing themselves. So that's another kind of concern here. In terms of misdiagnosis, in 2011, 9 patients took medicine from the previous year. And this is really important because, as I said, you're only supposed to be allowed by Oregon law to get medication to end your life if you've got 6 months or less. But if you're taking medicine from a year ago, then clearly you had more than 6 months left. And so a person who, in these cases, in every one of these cases, the person was misdiagnosed. They were claimed to have 6 months when they really didn't. Maybe the doctors even knew that they didn't, but again, as long as they act in good faith, they're immune from any kind of prosecution. This is one of the big ones that's really important too. As I was saying, depression might be a major problem because doctors are good at diagnosing cancer, for instance, not so good at diagnosing depression. On the form for you to get medication to end your life in the state of Oregon, there is a place for a doctor to check off to say whether or not you're depressed. But guess who does that? It's the attending physician. It's not a psychiatrist in all cases. And in 2011, you can see here, only one of the 71 patients were referred for psychiatric evaluation. In 2007 and 2009, 0 patients were referred for psychiatric evaluation. Approximately only 7% of patients in the entire history of the Oregon law have been referred for psychiatric evaluation. So here's a major problem. You cannot tell me honestly that in all those other cases, in all 93% of the cases, that the person was clearly not depressed. I would imagine that more people were depressed who were given the medicine than doctors realized. And like I said, doctors, oncologists, other doctors who deal with other kinds of conditions, very, very good within their limited purview. An oncologist, very good at treating cancer, very good at dealing with cancer. But in order to be good at diagnosing depression, I mean, that's why we have psychologists and psychiatrists who go to school specifically for that, because it's so very difficult to really know if a person is depressed or isn't. So if you wonder, are people slipping through the cracks here? Are people being given medication who probably shouldn't be given medication? Well, the evidence says probably yes. Probably people who are being given medication who are not competent. There are people who are depressed. There are people who are misdiagnosed. So the worry here that allowing physician-assisted suicide would lead to bad consequences, it has been proven to be somewhat true. The prophecy did come true. Now, does this give us ample reason then to argue that physician-assisted suicide should be illegal? Well, that's the more difficult question to answer. The more difficult question to answer is, are the abuses that are taking place, are those acceptable or are those unacceptable? And the reality here is that at the end of the day, we're faced with what some have deemed to be a really tragic choice. If physician-assisted suicide is legal and remains legal, you are going to have the risk that you're going to force some people, or some people are going to end their lives prematurely. If physician-assisted suicide is legal, there are going to be those who slip through the cracks. There are going to be people who are misdiagnosed. There are going to be some people who are coerced by family members to kill themselves. There are going to be people who are depressed, who end up killing themselves. On the other hand, if physician-assisted suicide is illegal, then you're going to force some people to suffer who might have benefited from hastening their death. If it's illegal, then there are going to be people who are just in agonizing pain that can't be treated, who are just forced to suffer. I actually just heard this quote recently as I was listening to an economist named Thomas Sowell, who I really like a lot. And in what Sowell said, he said, "In life there are no solutions, there are just trade-offs." And that is a great deal of wisdom, in my opinion, because that's exactly what we see here. There's a trade-off. There's not a real solution to this problem. Either way you go, you're going to hurt someone, and the question is, where do you do the most harm? In a way, we have to think like utilitarians here. Where are we going to do the most harm? Are we going to do more harm by having it legal and people killing themselves prematurely and people killing themselves really and truly against their will? Or are we going to create more harm by forcing a handful of people to suffer who could benefit from ending their lives? And the truth is I don't know, and I'm not sure anybody knows. But this is the tragic choice that we must face when we think about physician-assisted suicide. Either way we go, someone is going to suffer. What we have to do is try to figure out and look at more evidence, and this is something that no one has quite determined, to see where we're going to create the least amount of suffering in the world. I know you'd like to have a more firm answer to this question about physician-assisted suicide, and euthanasia. But the truth is this is a really complicated problem, and this is something that's not going to be decided in a 1 week class. It's not something that's going to be decided in the near future, because at the end of the day, the big question here that we need to deal with is, where do we do the least amount of damage in the world? Where do we create the least amount of pain? And that's something that's just, honestly, there's not a clear-cut answer for. So hopefully by going through this, you've been able to see the various alternatives and options when it comes to physician-assisted suicide. And not only that, you can see the underlying issues here. One of the big issues, as we've seen, is that of autonomy. And what the people who defend physician-assisted suicide claim is that it should be legal, it's morally permissible also, because it's a function of one's autonomy. The question we run into on the other side is, well, there are two kinds of questions. One, if we accept that autonomy is the philosophical justification and the legal justification for physician-assisted suicide, does that commit us to some other things that we don't like? And then secondly, we run into questions about, well, when does a person act autonomously? Is a person acting autonomously if they're depressed? Is a person acting autonomously if they're in a lot of pain? Or is it their depression talking? Is it their pain talking? So these are the kinds of questions that come up with physician-assisted suicide and the main philosophical and legal issues that surround it.